Either. Hi, welcome to Let's Locums. My name is Mark Royer. I'm an ear, nose, and throat surgeon and Locum Tenens physician. Our guest today is Dr. Pryor Brenner. Dr. Brenner is an accomplished ENT surgeon with a remarkable background in both military and civilian medicine. A native of Delaware's Eastern Shore, he graduated as a distinguished graduate of the U.S. Air Force Academy and earned his medical degree from the Uniformed Services University of the Health Sciences. His career has taken him across the globe, from providing life-saving care on the front lines in Iraq and Afghanistan to treating complex ENT cases at Andrews Air Force Base. Today, he's here to share his tips, tricks, and practical advice on thriving in locum tenens roles, drawing from his unique experience balancing both high-pressure military assignments and locum shifts. Dr. Brenner, thank you so much for joining us.
Hi, good morning, Mark. Good morning.
So you and I go way back. You were actually, I don't know if you know this, but you were the first locum tenens physician that I met.
I remember this very well. It was in Columbus.
That's right. Columbus, Indiana. Allie and I were getting ready to have our daughter, who just turned 10. I remember walking around the corner. You're sitting at the computer. They were, learning Cerner or logging into Cerner.
Yeah.
And I met you, and this sense of relief just came over me because I knew, number one, that my patients were going to be well taken care of. And I knew that I could just kind of relax and enjoy as much as you can when you're getting ready to have a kid the next week or so. And you came and you not only took care of our patients, but you also managed the ER, inpatient at the hospital there for us. And that was not, though, your first locums gig, right? You were in the military at the time. And tell us a little bit about that.
So my locums journey in the military, it started out, I want to say, around 2013, 14-ish. So shortly after residency, I started covering some local ER call through some colleagues I was working with. They were working with a local hospital, and I kind of worked into their call rotation there. And then I started getting calls from locums companies. At that time, it was really just Comp Health and Weatherly. And I ended up going with Comp Health, and they hooked me up with a couple jobs that weren't local, but within driving distance. So I started, and I think yours was, I think, the second or third place I had been, because it takes, there's a fair bit of administrative steps that need to happen before you step on site to cover a shift, between whether it's state licensure, getting credentialed through the hospital system there. So there's definitely some upfront investment. In some of these situations, you don't know if they're going to last for a month, 2 months, or if it's going to be a long-term endeavor. That's how I kind of got involved in doing extra work or locums outside of my military job. Initially, it was to develop an additional source of income and revenue. And that's how it stayed for probably the first 5 or 6 years of doing locums. And I had a chance to experience, several different sites during that time, and see a lot of different situations and office scenarios. And I was always very interested in talking to office managers and owners, and to find out like what their struggles were, what was the similarities, what was successful. And I think that really gave me a lot of insight, both for the military and for the civilian world, when people were talking about, how to increase access or how to set up, a multi-site group where, we did that in the military. They started building these things called product lines. So instead of having like the ENT clinic at Walter Reed and the ENT clinic at Fort Belvoir and the ENT clinic at Andrews, all like these single separate entities, they brought them together as to one kind of group that had multiple sites they provided care at. So a lot of these things were very helpful in doing that. And I've also seen some situations where you step into that, you get information from the locums company and you realize that it's not the entire picture. So this was definitely not your company. I remember stepping into a situation where the ENT group there was having a standoff with the administration there, because they weren't getting reimbursed for any hospital call. So they said, well, fine, we're not going to take any call anymore. And then in comes Dr. Brenner, to the rescue. And I didn't know. I was like, the scab crossing like the picket line, and not really a warm welcome. I'm so used to like, hey, very collegial. And I remember the welcome was, hey, you may be a great guy, but we don't want anything to do with you.
Oh, jeez.
I was like, wow. So awkward.
Yeah, right.
And then so I was like, okay, so if I see someone with a nosebleed or facial fracture, or if I do a trach, Am I signing out to you? And he was like, no.
Jeez, what a rough situation.
And he's like, you can consult the ER.
Oh, man.
And
Yeah, that's rough. Holy
so
cow.
so from that, I realized that there's a lot of nuances to these locum situations, both from the provider standpoint, who's doing the locums, and from the site standpoint, who maybe have never had locums before.
Mm-hmm.
So experience there and having boots on the ground is always invaluable.
And I think we chatted before you started to come to our site about the practice and like the call, stuff like that. Would that experience have been before? Do you remember? Was that before you came out working with us? Because, it's always useful, I think, to talk to the site. And I mean, the recruiters obviously should know that. The company should know that, not put their docs in that situation. Oftentimes it doesn't, there can be some horror stories.
Yeah.
But was that something that you had decided to do after that experience, or was this kind of thrown in the middle of your locums journey?
It was in the middle of the locums, and because it was going to be a short term. They were looking for probably like 2 or 3 months of locums coverage while they got people to the negotiating table. It only took 2 trips out there, and they sorted things out.
Now, at the time you started doing locums while you're in the military, did you have other colleagues who had been doing locums that you asked advice from, or that you talked to about doing locums while being active duty?
So a lot of the people who do locums would do it locally. I'm in the military. At least when I started out, most people who were doing locums were doing it and covering, local, civilian call at a hospital. Not a lot of people were traveling, definitely not, getting on airplanes and traveling. Some people were, but none that I had talked to. So in my initial journey with locums was, like I said, kind of developing and building a secondary source of income and revenue. So sometimes it would be just going and covering whatever patient calls or ER calls would come in. And sometimes those weeks weren't terribly busy. You may have, a dozen calls over a period of 7 days. Sometimes that's great. I called it kind of a working vacation. So there was times that, I would go in to do a locums gig, and I would have a bunch of other things that I would take with me, whether it was taxes or CME stuff or other work that I was working on. I remember one week I had, 2 children who were both doing chemistry and they needed a lot of help. So I ended up, thank God to YouTube, I ended up teaching a course in acid-base titrations over the course of the week. So, it's nice to kind of know that, that's one type of kind of locums arrangement where they don't really need a lot of help in the clinic. They just want you to take the burden of the ER call or the after hours calls. They say, hey, if you can take that burden off my shoulders, then I can just focus on seeing clinic. And that was very rewarding and a big relief for some of the groups that we've covered or continue to cover. That was kind of my initial, probably the first 4 or 5 years of locums. And then my goals kind of transitioned a little bit after that.
What are the unique challenges of being in the military and then doing locums during your PTO? I'm sure it varies between branches and varies between, maybe be different now, but at the time you were going through or your understanding of it now, what are the hurdles or challenges that a military doc would have to go through in order to be able to work locums?
Yes, so the biggest struggle is always a balance between access to care and providing care to the dependents and active duty members and retirees that are at your base where you're stationed, and you balance that with readiness skills. Hey, the things you do here stateside may be very different than the things you do downrange. Down here stateside, you may be placing tubes and doing sinus surgery and draining someone's, peritonsillar abscess or things like that. When you go downrange, you're taking care of someone who got shot through the face by a high caliber, high velocity round, or you're doing humanitarian aid for a kid with a huge facial tumor and stuff that you would probably never see in your, job, stateside. I think the biggest, so those are kind of the institutional hurdles, but in order for locums to be a successful endeavor, really you have to have a good relationship with your immediate supervisor. Sometimes that may be a clinic director or a department of surgery director. And then your commander in the Air Force, that's usually a squadron level position. That's usually the person who's probably, two above you as far as supervisors go. But you have to have their support. And how you garner their support is you make sure that you are showing that when you're there, that you're providing access, that you are a very competent and valued provider in their system, and also making the argument that saying, hey, in order for me to continue to be a valuable provider, to include when I go down range, these are some other things that I need to do. And when you're taking your own, leave that's saved up to go do locums, I think that that's kind of your own choice. And some commanders like to micromanage and get involved and tell you how to take your leave. But at the end of the day, it's kind of your leave to do what you want to do with, but you still need support. If you go toe to toe with your commander, it's probably not going to end up well for your locums endeavors.
So we love working with our military docs. It allows them a way to have some extra income. You mentioned the readiness skills, downrange readiness skills. I like that lingo. So, depending upon the site, they may have more facial trauma at the locums position than they would in their normal assignment. That helps with readiness. But there's also some like the paperwork. Does that vary by like military branch? For example, like hours worked and stuff like that. Occasionally, we will need to complete those forms for our docs that work with us.
Yeah, so that's kind of a moving target, and it's dependent on the site. Some sites want very, very rigid recordation of hours and patients treated, CPT codes, ICD-10 diagnoses.
That you would submit then back to the military.
Yeah,
Yeah, okay.
more CPT codes because they're trying to track what cases you're getting from locums. I think that's kind of where my locums path or journey kind of transitioned when I was knowing that I was going to be deploying to Afghanistan. And I've always been involved in a lot of the readiness skills and development and discussions within the Air Force, and to include later on, with, all the three services, the Navy and the Army. And the question is, like I've been stating before, how do you keep your surgeons ready to perform these different procedures and life-saving procedures down range when they're not doing it very much, in garrison or stateside? It would not be uncommon for me to talk to a fellow staff at one of the major institutions like Walter Reed or Fort Belvoir, and they may go 5 years, where they have ICUs and things like that. They may go 5 years and haven't done a trach. They may go 5 years and haven't done a facial trauma other than maybe like a closed nasal reduction or something. Just because you're at one of the bigger institutions in the military doesn't mean you're going to be getting these cases that are going to be valuable kind of going down range. So the more I got involved in that and the more I started looking at the different options for the military, there became I saw a lot of distinctions and differences between the current programs the military had, and then the experience I had in locums, especially when I started looking for, more cases that would, allow me to stay more competent when it came to going down range. And that's when I kind of had a little bit of change in my locums journey. No longer was I interested in as much as the revenue income as I was interested in the experience of getting kind of more currency cases and using it as a tool to stay competent in the military.
So for ENT to stay competent in the military, specifically, you'd be looking at airway and facial trauma. Would that be accurate?
Yeah, so the summer of COVID, I sat in a room with Army and Navy colleagues for about 2 weeks, and we hammered out data from the last 10 years on spreadsheets and looked at all the trauma cases that have been done downrange. Not just trauma cases, but all the cases that our deployed ENT colleagues have done for the last like 10 or 15 years. And we have all that data, and we sorted it all out and, came up with, the most common cases. And, by a landslide, it was facial trauma and airway. And people weren't doing, fast surgeries. They weren't doing, a lot of rhinoplasty downrange or anything like that. So that was really like the top two, knowing how to approach and treat facial trauma, knowing how to address penetrating neck wounds, and then knowing how to manage surgical airways were the big ones.
So is it possible to get a locum shift approved as a military physician, specifically with regards to ENT, if you have a site that may not be airway heavy or facial trauma heavy? Did that kind of process change? the approval process for these shifts?
So for the Air Force, I think it kind of depends on, they have this new program. It's about 4 or 5 years old. It's called Mock R. And what it allows the commander to approve, I think, a 4-day pass for someone to go and do locums work. Now, the caveat is if you take that 4-day commander approved pass and go and sit in a hotel room and cover like 2 or 3 calls, and then come back and you're like, hey, here are my cases that I did, and it's like 2 nosebleeds and a peritonsillar abscess. And then if the commander knows what they're looking at, they're gonna be like, okay, so I don't know why I approved this pass for you. It really didn't. You're not any better
You're right.
ready, suited to go down range than you were before you left. So for that type of locums engagement, I would say just use your leave like you would normally. Submit for your leave, do your locums gig, and then come back. But if you're going to a site that's heavy on trauma, that's absolutely, when I would still in the military, I'd come back and I'd say, hey, look at these critical cases that that I did while I was there, and I would log them and make sure that they're recorded so that you could say, hey, this is a good program. We should continue to support this, and that's still very dependent on the commander and the individual. So you have to be smart in what times you're asking for the command to approve one of these special passes.
Well, I've certainly appreciated your help navigating that, because especially at our trauma level 1 trauma site that you work at and help us coordinate military docs out there, because I do think it's a huge value add for the hospital to be able to have that help. But then also it sounds like to keep our military otolaryngologist ready, in case they ever need to be called upon to do some of the facial trauma and airway stuff. So that's fascinating. Excellent. Do you have any item that you bring on a locum shift that you would be like, it's like your go-to item or go-to equipment that you bring with you?
So it's funny you ask that. I think it's the same thing that I would always take to the trauma bay when I was in Afghanistan. No matter what time of day it was called, we had these trauma beepers, and when they went off, you'd go report to the trauma bay. You'd be ready for however many people they were bringing in. And the two things I would always have my headlight, and I always have a nasal speculum in my pocket. And the reason for the nasal speculum, usually I have like one of the longer ones, is because they are wonderful for airway. So if you have to make a crike or hold open an airway while you suction and get a tube in it or something like that, a nasal speculum is a wonderful tool to have. So those are the two things I always have.
I love it. Headlight and a nasal speculum. It makes a lot of sense because, that's going to be hard to find, right? So you bring your nasal speculum with you. I always like, whenever I have these, because, we love wilderness medicine, and I know I love it's like, what's the one equipment? I've always kind of thought of hemostat, but if you're bringing that with your go-to trauma bay, that'll be easy to find. There's hemostats everywhere.
Yeah,
but try to find a nasal speculum in an ER. Good luck with that.
Yeah. Well, you think about airway, right?
Yeah.
And how many times have you been managing with a trach, or a trach that has some plug in it or is narrowed, and or if you heaven forbid have to do a crike on someone, you need something to kind of hold that tissue open while you suction whatever clot and mucus is in there before you put your tube in there. So a lot of times that's tracheal spreader is how's that much different than a nasal speculum? It's not.
What common mistakes do you think new locum physicians make, and how would you recommend avoiding them?
So I think the most common mistakes I've seen are probably more personality based. And you have to remember that when you are showing up for a locums job, it's not about you. And you may think it's about you. You may think it's about what you need and stuff like that. But you're really there to provide a service and provide support. And that you mentioned the sense of relief that you had.
Oh,
you saw this.
It's great.
So that sense.
Well, you have a presence about you. You just you have a presence that is just like, okay, we're all in good hands here.
But
everything's fine.
That's what you need to instill. That's what you need to instill, is this level of confidence. Like, I've got it. And remember that you're there to provide a service, and people are usually employing locums because they're overworked, they're over consulted, they're getting hammered, they're stressed out, they're burned out, all those things. And so when you show up, you need to be like, the relief is here, and to let me know how I can help. How can I interact with your practice, with your hospital, with your ER, to not be a burden and to provide a relief for what you need to do. And sometimes that's just clinics or practices will say, hey, if you can unburden us with ER call and hospital consults and after hours calls, that would be a huge impact. And for the week that you're here, if you could take care of that, then we would be eternally grateful. And sometimes that's what it is. Other times it's like, hey, if you can, see, 15, 20 patients a day and help us with our backlog of, 4,000 consults in the system, that would be very helpful. So a lot of it is assessing the need that they have, especially if you're kind of one of the first ones out there, assessing kind of what the need is and working yourself into that position and viewing yourself as a relief. You're like the backup pitcher coming in. And I think when you view yourself that way, that most interactions are going to be positive ones.
How do you see locum tenens evolving in the next 5 to 10 years, especially with regards to the military?
So I'm hoping that it plays a larger role in the military's mission to keep ready surgeons. And when I say ready surgeons, ready to go down range. As you know, the war in Afghanistan has kind of spooled down, so we don't have any, huge major conflicts right now in the area, thank God. But I'm sure, if history is any predictor of the future, there are future engagements around the corner, whether small or large. There's always going to be a need for, head and neck surgery to be downrange and close to where people are being hurt. I see the role, and I hope that the role of locums grows to meet the need of, keeping military docs ready to go downrange. And I've been a huge proponent of this when I was in active duty. And the mindset comes from when the military has several programs to keep that they've had over the years through training agreements, whether it's, through like MedStars or shock trauma up in Baltimore. They have a big MedStars program out in, I believe it's Kansas City. So they have a lot of these programs where you go for 2 weeks and you are involved with facial trauma care and part of the facial trauma team and things like that. I think the downside, and I have not personally done any of these programs because I've kind of pushed back against them. But every one of my colleagues that I have talked to would say that you're, part of the team, which means that you're not really making any of the decisions. You're not the first call. You're just kind of plugged into the cogs of this trauma team. And when you show up to the OR to do a facial trauma case or mid-face fractures or whatever the case may be, you're usually 2 or 3 deep down the table. There's a staff, there's a fellow, there's maybe some plastics fellows, and then some residents, and then maybe a med student, and you're in the mix there. You're definitely not driving that ship. Very different than when you're showing up, you're on locums. This is your first night on call. You don't even know where the damn ER is. You're like walking around. You're not sure if your ID badge works. You don't know where to get scrubs. And this is the life of your first night on call for a locum site.
I completely agree. The value, you're adding value to the hospital. The docs are getting paid to do it, and then they're also getting this readiness training that benefits the military and all of us. So yeah, that's excellent. I hope that it does continue to be something that docs are encouraged to do.
Well, I was going to emphasize how I felt when, on call for locums. When I was making the decision, I had to know, I was the first one, looking at the films, and, I know if they didn't already do 3D recons, I have to ask for the 3D recons. I have to know what plating sets there are. I have to know what the capabilities are. Do I have neurosurgery available? Is IR available? So you kind of go through all these very important kind of, iterations and questionings, which when I reflected on it, I was like, you know what? That's the exact same mindset that I had when I was in Afghanistan. Because you need to know what you have, what your capabilities are. You're making all the decisions, and you're making what's best for the patient. Sometimes that patient, is going to be, going to a very well-supported medical system. Other times that patient may be living 2 hours away and has transportation issues. And that's probably not someone I'm going to rely on coming back or I'm not going to let them monitor, some airway
Hmm.
issue, or like, hey, if you start feeling short of breath, you come on back to the hospital because that's probably not going to happen. So the similarities there were just uncanny. And that's why I'm such a huge proponent of the locums, because I think when you look at the skills needed and the mental, processes that need to be in place when you're getting ready to deploy or being in some austere environment, they're very similar to when you're taking over call at a locum site.
So we do a fast five with all of our guests, usually related to some unique factor, some X factor.
Okay.
It's kind of hard to pick with you. I feel like there are so many X factors, Brenner. But one feature that stands out is the number of children that you have. What's that number?
So it's 8.
8 children.
It's
So
8.
this has even changed since I wrote this. These questions at the time. I had 7 children. So how old is your youngest one?
She's 21 months now.
21 months.
21 months.
So, okay, fast five. So parenting, medicine, and military life. All right.
Mm-hmm.
Parenting hack. What's your go-to trick for keeping 8 kids happy while managing a busy physician schedule?
Rigid dictatorship.
Something tells me you're not joking. What's the best lesson from military life that's helped you as a parent?
Yes. Can I repeat the first one?
Right. You can give the same answer.
No, I learned a lot of great things at the Air Force Academy that have carried over to parenting. So sometimes I don't care who did it. I don't really care who did it, but the problem needs to get solved. And until the problem gets solved, everyone's in trouble.
What's the most meaningful family moment that made you realize you were balancing medicine and parenting just right?
Does sewing up a child on the kitchen table count?
Yeah, absolutely. Making the most of it for sure.
I think I was treating a little girl over in Afghanistan, and the kids put together a care package with like their own toys, and like they put together cards, and they were like putting themselves in that patient's shoes, and it was really, really touching. And we were able to drastically shrink this tumor, and this gal, she had a microcystic lymphangioma, and she looked like a little girl again. And like the changes in her mood, her affect, she was smiling. And then when I, gave her the box of toys and cards and stuff like that, it was beautiful.
Wow.
It was really beautiful. And I was like,
Giving me tingles, man. That's crazy.
I know
Goosebumps.
it was really cool. And I was like, okay, this is cool. And yes, it's hard being away from your family, but the kids get it. The kids get it, and thank God, Daddy came home okay. And but it was a really cool moment.
What's the funniest or most chaotic moment you've had to juggle a locum shift with family responsibilities?
Um, Gosh, that's a hard one. I don't think I've ever really had incredible like emergencies or anything that have happened. It's usually one of the kids needs something, and I'm in the middle of clinic, or if I'm in the OR, and then I can usually pretty quickly, get them the information they need. I think one of the ones was my wife didn't have the Chipotle app or something like that, and I was scrubbed into a case. I forget, I was draining an abscess or something like that, and the nurse is reading out the text in the ER in the OR. It's like, can you please order these bowls at Chipotle?
Got to get my readables.
And I was like, honey, you need to get the app. But that was a pretty funny one, and we all had a good laugh in the OR about it.
What's one lesson you hope your kids learn from watching you be both a doctor and a military veteran?
I guess the same lessons that I tell all my kids and colleagues and people who are looking for, life advice. I tell them, the find something that doesn't feel like work more than half the time. And if you can do that and it is intrinsically rewarding for you, and you can put some bread on the table doing it, then you've found what you need to do in life. And if you can't put bread on the table doing it because you're a struggling artist or musician or something like that, then you better have a backup plan or some backup skills to allow you to do the thing that you want to do.
Because mom and dad have 8 kids. Like, you're not going to get.
Yeah,
I spread that around.
Say when you spread your wings to jump out of the nest, you don't know that there's a foot right behind you that's going to give you a little help if you need it.
Well, that's great. Dr. Brenner, thank you so much, Pryor, for taking the time to chat with us today. I think you have such valuable insights. Thank you for the work you do for our company, helping us run our sites, make sure we get excellent docs, and caring for patients through our company. Thanks for the work you did for our patients when you were our locums doc, when we were employed. And of course, for the work you have done for our country with your military service, helping our physicians in the military be ready to go to care for citizens, not only here and other military members, but I've always been impressed when I've talked to my friends that are in the military, the care they provide to the communities that they're working in. Like you mentioned that one girl, I'm assuming she was like from Afghanistan there locally, right?
Yeah.
Yeah. Yeah. It's great. Well, thanks so much, Pryor. I appreciate you.
All right, Mark, it's always a pleasure. We don't get enough time to sit down and chat every time. I feel like we could, talk for a day and still have, 90% of things uncovered.
I couldn't agree more. So, all
All
right,
right,
we'll
be
see you later.
well.
Okay.